Jim Joyce. Happy Wednesday.
Happy, happy
It's
Wednesday.
the it's the Thanksgiving Wednesday, even though tomorrow is Thanksgiving, but it's our
Yep.
special Thanksgiving episode. I don't know why it's special, just it's a Wednesday.
Just
But I'm
giving thanks.
thankful for our friendship, and I'm thankful for us doing this now. I haven't checked, I think episode
Yeah,
156, 7, something like that.
I think that's
So
right. It's a
that's
great time of year. A lot of reasons to be thankful. I'm equally thankful for us surviving lots of stuff together now, lots of podcasts, lots of conversations. As I think Dan was saying, that we kind of invite everyone in for a conversation, like into our virtual living room once a week, right? So,
yeah, yeah, exactly. Well, listen, excited. There's Health Tech Forward next week. Unfortunately, my dates got screwed up, so I'm actually not going to be there, but a bunch of people like, Ritesh and many others are coming in. So Barcelona, I'm gonna miss being here for it. So,
yeah, yeah, that looks like a great event.
but shout out. So anyways, I'll let our guest in.
Awesome.
So Umang and I met, I want to say it was somewhere between 2013 and 16, maybe. I don't know, something like
Oh,
that.
wow.
It's been ages. I was just reflecting, Umang. I think we met, before I started at Bayer, maybe right after, something like that. But anyway, somewhere and I still remember the Babylon office. Heading in there, I think Mairi Ali, and then we met. So I kind of vaguely remember it was like another, decade, previous decade.
Yeah, well,
But
I'll get a
well,
Babylon office full of trees and now full of fish, right?
I
I love
see.
that's uh, Jim Umang Jim, and originally no offense to Ed Clubhouse, but this is actually going to turn out better. I promise everyone. So originally, I think Jim, you and I also chatted on this. Ed reached out
Right.
and said, "Hey, Umang and I would love to just kind of dive deeper into AI." Ed has been a guest on the show, so this would have been a huge exception that we made. And it would throw off our flow. But Ed texted me this morning that he unfortunately cannot make it. We will miss him, but we're going to have some fun getting to know Umang. So, Umang, welcome to the shot. And we'll do our normal approach. Tell all of our millions of listeners and viewers everything about yourself. And no, I'm kidding.
In
But
nine
start
minutes.
personal, professional, however you want to go, and
it.
we'll go deep or not or shallow.
Yeah, and
Yeah,
where are you calling from right now, maybe too?
yeah. Just hi, Jim. So calling from Weybridge, sorry, so just outside of London, on increasingly dark and cold nights, but warmed to be here.
That's
Thank
UK.
you for having me.
Great.
So, shall I tell you a bit about me?
Yeah, love it.
Yeah.
I always start this and I can't help myself. And like, I always start by saying my proper job is I'm a pediatrician. Like, it's so
Okay.
core to my identity. I still treat patients in the NHS 1 day a week at Frimley Park. And truthfully, that I love that job. Like, there's not a better job than trying to make children better. I don't think. I'm also the chief clinical information officer at Microsoft, and I'll sort of tell you the story from where I started the sort of medical school up until there, if that's okay. So
Yeah.
look, I
You can go back to
well,
birth. We always joke
go
around,
back to
man.
where
Like
Yeah,
you can go. We
yeah.
got we got some time.
Before you were a pediatrician, you were probably a pediatric.
yeah. Actually, it's not bad. Like I'm second generation Asian, and like I remember my dad being like, "Oh, like what are you going to do?" And I was like, "Well, like I don't know." And he's like, "It's okay. Like here, I'll give you a list of choices. Like, do you want to be a doctor, lawyer, an
A
engineer, a
doctor,
plumber?
an
Just pick a
accountant. Yep.
vocation. Yeah, like just done." Um, I sort of happy child didn't grow up above a corner shop, and he said, "Look, you could do those things, or you can do this life, which is 7 days a week in a shop." And I
Okay.
said, like, he didn't love it, like absolutely loved it, like enjoyed the community that we had. And when I was thinking about doing medicine, um, it was very much that feel I had in mind, right? Like people would come into the shop and say to mum and dad, oh, hey, I've got this problem, or how about this? And you'd know them. And so I grew up wanting to be a general practitioner because
Mm.
the best member of our community was Dr. Singh, who we
Okay.
all loved. And we'd go to Dr. Singh for like almost everything, like, hey, I don't know how to do this. Do you know that? And I thought, yeah, I remember thinking, that what a great guy. Wouldn't it be great to have that sort of impact, influence, and watching my parents influence and others, and given the opportunity to go into healthcare and medicine, if you're good enough to do it, then do it. So I went to medical school. Um, in Southampton. From there, I was like, do you know what? This is a great job, right? Like, as you both attest, right? There's no better feeling, I don't think, than making someone better when they're scared, or being in a privileged position to try and help somebody. That
Right.
doesn't have to just be through their health, but like generally, like that's sort of an easy win, right? Like something's gone wrong. I want to be able to do something different to change that course and get that better. Here's a great way of training through it, and you get the moniker of being a doctor, and you can walk around with a stethoscope and everyone thinks you're lovely. Like, great. So that was it. And so graduated, went straight into pediatrics again. Loved that.
That's always the big money is pediatrics. I'm joking.
Yeah. No, if I'm allowed to get all the way back, I really wanted to at the beginning of everything. I was like, I'm going to be a psychologist because the human brain is fascinating.
Mhm.
Like, I remember going, you don't get paid very much to be a psychologist. So, I like what do you get paid more, but in the same vein? So I thought I'd become a psychiatrist. So I thought I'd be Dr. Singh, but actually maybe I don't want to just carbon copy that. Like, and primary care is one thing, hospital doctors are cooler. There's more programs about hospital doctors on the TV than there are, like in ER, there about PCBs, right? So I'll become a psychiatrist. That seems cool. But actually, when I got to medical school and went through it all, I just thought pediatrics, like, it was lots of fun. You can play Xbox on the wards. Like, it had a vibe that just felt right for me, and
Right.
straight into it. Um, and then as I was going through it, you realize, or I realized quite quickly, we were figuratively and literally sticking plasters on problems. And I thought, again, I don't want to I don't want to wake up at 50 and say, oh, I knew that was going to go wrong. We were always going to have more patients than we have capacity for. We weren't
Yep.
changing the dynamic in a way that I thought was going to be sustainable. Rather than wake up at 50 and go, oh, I could have done that, but I didn't. I thought, you know what, maybe I'll look at how I can try and help that. Had some great mentors along the way that said, okay, well, maybe you should think about leadership or getting different skills to augment and help us through these challenges. The number one challenge that kept coming up was that we just can't make the economics work. So I talked to lots of chief executives, and I was doing a leadership program with the NHS Leadership Academy, and they'd say, look, Umang, we love your enthusiasm, but the problem is money's our burning platform. We need like more accountants, less clinicians running services. And I thought, how hard can it be to learn how to use Excel? Right, like, you'll get my career journey, but I ended up at Microsoft just to learn how to use Excel almost. But I was like, well, I can learn Excel probably quicker than you can like do the 5-7 year medical degree. But where can I go to
And
learn
just
about money?
to be clear, money is still the burning platform, right?
Yeah.
Okay, just I was
Yeah.
trying to
No,
be,
we had it. Yeah, I think every health system, right? Like,
yeah,
every
exactly.
so much of health, so I thought, where can I learn how to do that? Insurance seemed to be a good place to go, so I went to work for Aviva, the insurance company, and my wife said, look, you love pediatrics, like everybody knows you love being a doctor, like this would just be a thing you have to do. You realize how rubbish it is working in an office, wearing a grey suit every day. You're like, so don't quit, basically. Like, so I went to my first boss and I said, look, can I keep a day a week at least in practice? And
Yep.
and he said, you know what, I don't care. Like, if you can't finish your work in 4 days, I'll fire you. If you think you can finish all your work, then carry on. So so I was like, at least very honest. And from Lee, where I work now, they were like, yeah, okay, do you know what? We're always chronically short-staffed. Come in, pick a day. And that was, what, 11, 12 years ago that I've been doing that day a week. But I was at Aviva, that's my beginning part. And whilst we we're at Aviva, the whole point then was thinking, okay, well, I now understand how money flows a little bit. Like it's a smaller population, it's an insurance mechanic, less of the complicated stuff. But the two levers we have in insurance were how do we get more people to buy insurance to reduce the risk? One lever. And then the second lever was how do I control the cost in order to limit my claims exposure? And it was that second lever that really got me thinking, well, that's what we do across any big population, any big provider service. What can you do in that? That led me thinking, well, you've got to get more upstream, right? Like the only way to really start solving these issues is to try and cut them off at source. We all know that prevention is better than cure, but how do we get there? How can we start? And that led me to talking to Ali Parsa, who founded Babylon. And I said to Ali, we met coincidentally we were supposed to have, I think, a quick coffee. About 3 hours later, we were there going, like, this is exactly what we need to do, convincing ourselves that like telemedicine was the solution, at least to some of the problems that we faced. And he said, I'm starting this company, Babylon, you should join us. Let's see what happens. And I thought, well, why not? Right? Like, let's see. You work at a startup, you don't expect it to be successful or survive. For anybody that's worked closely with Ali, Eugene, you'll have this. Nobody quite expects to be there for that long anyway. So like, there's always a good chance that you won't make the team. But I spent 7 years at Babylon. We took it from that team of 10 to about 3,500 in the IPO. IPO'd amazingly. We became the largest GP practice in the UK. Very proud of some of the work we did, especially in the readiness of getting, like, we didn't predict a pandemic, but being ready for that. I think we led the way and laid a foundation for people to know that it was safe and effective to carry out stuff in different ways. And we IPO'd, and it was great. And Ali was moving to America, and they were looking at what we could do in the US market. I was more wedded to here. And I was like, amazing we've got this far, but I wonder what next. And then Microsoft phoned up and said, oh, hey, just out of interest, what are you thinking about doing next? Like, I'm not sure. And they were like, well, ever thought about big tech? And I was like, well, no, not really. Like, why would Microsoft need a doctor? Like, I don't get it. Like random sort of. And they said, well, if you think about it, do you think the NHS could run without Microsoft? And I was like, no, truthfully not. They're like, are you sure you don't want to come and have a chat about what we're planning, what we're doing, and how you might fit in?
Right.
Sort of one conversation and then another conversation, and then they offered me a job. And I was expecting this process of like, it's going to be a lot harder. And they were just like, we're committed to trying to do something in this industry. Like, there's only so far you can take it with technology led teams. We need more industry expertise. That was about 3 years ago, and here I still am.
And time flies. I'd love to rewind back to your point a little bit on, I still remember kind of the very, very, very early days of Ali. And first of all, same thing. I mean, when I met him, you can see his brain is just moving a million miles a minute, right? And I think the premise of kind of technology first for triaging and as a product versus then moving, because to me, healthcare is still human in the loop, right? I think many individuals try to kind of, well, AI is sexy, which I think is going to get us to the topic that we originally with Ed brainstorm. Yes, there's tons and tons of use cases, but I think sometimes people forget to put themselves in that patient chair, as they're struggling through, and, is a human being going to replace AI? AI going to replace a human being truly in the near future? I always say never, right? But so rewind back kind of in the early days with the 10 people and being I'll call it the more diagnostic AI driven tool. And then just the thinking through the larger GP practice in UK and all this, kind of how you guys were thinking in that room. And of course, I think Ali did promise to come on the shot at some point, so I think hopefully with his new gig now, he will.
Good. Yeah. Well, I'd love to. Do you know what? I've never done a podcast or a thing with Ali since we've left, because I wonder how much we'd contradict each other. We'll have to find out, right? Like, we can
Yeah,
just,
we'll compare the
yeah.
two episodes. All right.
I'm I'm sure everybody's saying. I mean, what I'd love to say was there was this massive, unique insight and like intellectual rigor, but it wasn't. It was just the dumbness of healthcare is too expensive. How do you lower the unit economics of delivery of care? Like we have this mission statement, which is not like how do you make we want to make healthcare affordable and accessible and give it to everybody on the planet. And of course, this challenge is if you pull one lever, so I make healthcare accessible, but I don't make it affordable, then actually that's like torture, right? Like saying, oh, I
Mhm.
can save you, but I'm not gonna. Like that's just morally wrong. So then we're like, but we could make it accessible. We knew that. We could deliver it we were very confident we could deliver it remotely, well enough to get part of the way through a care journey. And of course, now post-pandemic, I think that's been proven to be true. But so that side was relatively simple, but the affordability side was still, doctors don't want to be paid less sitting in a computer behind a computer screen for their expertise. You don't get to train less or have
Yeah.
less, you take less exams if you're doing remote care versus physical care. So the unit economics is always a challenge. And that's we were just like, what is it that we can do to make care cheaper, simpler, better? Cheaper was our sort of mantra. And on that was like, well, we've got to save the time of the clinician, firstly, which is why we got
Hmm.
into the symptom checker look like? What can we get people to do to self-serve? We've got to bring care forward. So we've got to stop people from getting the cancer. That means that they've got to have a major operation to something that is just a biopsy and then a quick day case, or even better, avoiding that altogether. And we've got to try and find that sweet spot that allows that to be done at scale and relatively uniformly across a population, which is why we went into primary care. So um,
Hmm.
so we're such bigger because we're like, well, that's a place we thought we could have the most impact. Was okay, great. In here, we can see everybody and try and like whatever their problem was, pull it forward where we could pull it forward, reduce that overhead cost where we could reduce that overhead cost of clinician time. And I think we did pretty well. Like I think like we flamed out by the end, and it didn't quite go to plan. But we were talking about this a bit before, right? Like I love the fact that no one can ever accuse us of not being ambitious enough, right?
Right.
Like most of healthcare is like actually like I couldn't quite scale it. We're like our problem was we tried too hard to be too big,
Right.
and they didn't work out. But I'm very proud of where we got to and what we did do.
And when you look at that, when you're trying to, with one of my, my last company, this kind of this intake process, like when you, I always think about these patients that are coming in the front door, and you're trying to service them, and you're doing your symptom tracker. What's the real trick there? What's the challenge of getting this? You want to treat them uniformly, but then you ultimately have to treat them for the condition that they have or what they're presenting with. And you want to do it quick, but not feel rushed. What's the secret, or what's the big thing that you've learned? Or if you had AI tools today, how would you
Yeah,
change it?
yeah. Two things. I think one is like trust. So like yeah, it doesn't. This is not just about the person or the patient has to trust the thing that they're doing because they're scared. Like if I'm
Okay.
buying a jumper, I don't need that much trust in the process, right? Like I can
Right.
return it, I can not use it, whatever.
Right.
Like in this, I've got to trust the thing, and we can talk a bit around that like we're obsessed around that at Microsoft, for example. Like what could, like if you mess up the trust, you're done for. It doesn't matter how good the thing
Right.
you've got after that. And then the second, this is where I think AI really excites me, but in the most boring way. The secret to that, Jim, I think, is time, right? Like the problem we always have is we live in a world where we try and limit the amount of time. So when you're thinking, how do I save money? I cut the time the patient spends with the doctor or with a thing.
Right.
'Cause that's a unit economic change.
Right.
Now, of course, you can go, well, I can give you more time, like working through your symptoms in a way that,
Right.
it's a bit like I could listen to this podcast at 1.2x speed and still
Right.
deliver the content. Well, what does that really look like in healthcare? So I get more content for less time. Like we've
Right.
never had that dynamic in healthcare before. We've always had, oh, no, we're trying to limit the content. Um,
Right.
and that could be the same of, for example, like why don't we do whole body scans on people? I mean, there's a lot of reasons, but one of them is who's going to read those scans? Well, Well, now I've got tools that might let that happen.
Right.
I think that time element will be, well, I'm
Yeah.
very hopeful that will be a bit of the secret sauce.
Speaking of full body, I'm actually looking forward to the Neko health test. I have it scheduled now in London, December
I think
18th.
we've
So
got
looking
that.
forward to it. But it's interesting to your comment way earlier. There's access now, but certainly affordability is not for everyone, right?
Right.
And I'm super curious to go through this process. I've seen, Vishal Gulati tech, on X, Twitter,
This
kind of
is
respond. It was phenomenal, right? So this is the Spotify founders, I guess relatively new startup, right?
okay.
Um,
Yeah.
so full body scan. Yeah, I'm just looking up Neko Health, right?
Okay, cool. I'm gonna book them for that. I'm gonna book it.
It's quite hard though. Like they're fully booked, right? Like this, and it's
Ten
Well,
thousand in the queue or something. So it's
yeah, yeah,
crazy.
yeah. I
well,
mean,
even
it's the
like
idea is
this.
like I'm going to book it, and I was like, but I can also just book my own scan if I wanted to scan and
But
um,
what's interesting is when you think about this, like I'm like Zappos is coming to mind. Remember the famous kind of where who was the founder of Zappos, but it was the shoe company, right? They were selling shoes,
Yeah.
and he said he gave customer service people as much time as they wanted on the phone because we had the marketing department that was trying to get hold of customers, and we had the customer service department trying to hang up on customers as fast as they could, right? And you have this dichotomy, which is you have so much of the healthcare system trying to find these conditions and screen people better so we can find the needle in the haystack. And then you get the GPs under pressure just because of time to like hang up on the patients that have these conditions. So you got one side trying to get rid of them, get them out the door, the other side trying to bring them in. And you're going, well, what if we just spend some more time talking to them? Could we, solve both those
yeah,
problems at the same time, right?
Yeah.
yeah, and we've never had that before, like in healthcare, because again, going back to that trust, like I can't just talk to an automated robot that just has a deterministic outcome. Like that's a
Right.
waste. I'm scared. Like you can sort of do it in a joyful scenario. Like I can phone up something that is taking me through an algorithm to help me choose, I don't know what car to
Yeah.
buy, what shoes to buy. Um, or I can do that with an agent who I can incentivize in a different way, but actually they don't have to spent 5 years at medical school or 3 years at nursing school or had the
Right.
training or carry that risk, right? It was the other problem. So when you think about healthcare, I don't think people that aren't doctors or nurses or allied health professionals, like you carry so much risk on every
Right.
decision you make that's why we like everyone's like, oh, why do the doctors always ask me the same questions again and again? Like because it's like because like A, we
It's
want to
some,
help you, but we carry that risk. So I can't not do it in the same way. Like if I'm selling you shoes and you don't buy shoes, it's sort of okay. But it's
Right.
not okay if I don't convince you that you should have this blood test, start this medication, or whatever else it may be.
Right. We were talking about, we never got them on, but the guys from Let's Get Checked are interesting how
oh,
they
yeah.
start. They started and they achieved trust in a really interesting way because they started off at sexual health. So and it was the anonymity that allowed people to trust them because you didn't want to go to the doctor and talk about embarrassing condition, but you would go to a website and disclose it because you just want to get the test to figure out if you're at a problem or not. And but so they started off in that way, and they actually gained huge levels of trust. But then it went into cardiovascular conditions. Well, maybe I also don't want to I don't want people to know that I might be sick or I might have a concern. So you had this interesting where they got trust by actually being anonymous, and
Yeah.
coming to
So,
the system.
so we'll do a call out to Peter Foley and we'll tag
Yeah,
him because I know we want to get him on, especially
yeah,
with the Truepill acquisition recently, right? In the last 6 months. So it's
right,
interesting
right.
diagnostics. So we'll save that one for another episode as well.
What
Um,
do you think about that and the not the anonymity side of it? That actually could you might trust something if you feel like you only know them in a certain window.
I think I think, again, that's the beauty of where we are now with large language models and agentic agents or whatever, because they're adaptable, right? So I think exactly some use cases I really don't want to talk to somebody that, like, it might be embarrassing. They're just going to tell me off. They're going to tell me like it's not my fault you smoked or the fact you're overweight or whatever else. So some of
Right.
them. In others, of course, you want it entirely the other way around, where you're like, actually, like I need to lean on you as a
Right.
thing, so I want to keep coming back because it's a mental health problem or a um, I'm pretty sure I'm well. I'm just worried. Like, like I
Right.
always give the example of like 15-year-old girls that come into my pediatric department with headaches. Like fantastically, 99.9% of them don't have a brain tumor, but everybody walks in thinking I've got a brain tumor. Now,
Things.
what we want in that is the ability to say, let me help you walk through a process. So my view of what I do at the moment, when I see them on the triage card, is I find them in the waiting room and I'm saying, oh, hey, look, read this Wikipedia page or this NHS, this resource on like brain tumors. Because when you come in, I'll talk to you about brain tumors.
Right.
If you come in and I just convince you it's not brain, I don't talk about it because it's like so far down the list of reality that will happen.
Yeah.
You'll go,
Right.
oh, did they not think about that or not? Or even I say to them, I say, read this thing and then come in and tell me what you're scared about because, like,
Right.
tell me that because that's part of it, and then I can tell you what I want to do to solve it. But if I'm not addressing those two, now I
Right.
think huge world where that bit can be done in a much more dynamic, powerful way with the new technologies. Going, well, great, I was able to chat to my chat GPT equivalent and go, do you know what? I know this is silly, but it's just that my gran died of a brain tumor.
Right.
Like, I know that's silly because she was 94 when she died, but that's what's worrying me for something to say, okay, that's okay. Like, mention that to your doctor. They're not going to think you're silly. It's all too
Yeah.
often you see the third time the patients come in, then they tell you, and you're like, well, actually, the first two times when, like, I'm, empowering them to have that conversation would
And not
be,
be nervous. Yeah. Yeah.
yes. I think that's how you then build
So,
trust in different ways.
so are you also saying a little bit that if there's some level of stigma associated with whatever that is, then the human may more likely chat with more of a chat GPT or AI versus something that's much more maybe emotional that, you need a human being to kind of really lean on. Is that kind of how you, or not necessarily?
Not necessarily. I think for certain use cases, I think the other one is that you reduce the variability. So again, I tell this story like my dad always talks about coming to England and not knowing English and being so afraid of like opening the door to the milkman, let alone going to a doctor
Right.
who might
Yeah.
like
Right.
make you feel silly or what, like, or you're scared. So like imagine being able, we know that 25% of people that like, we know that if you don't speak English as your first language and you walk into an NHS organization, you're 25% more likely, so 4 times more likely to come back in again with the same problem because we've not so
Right.
that costs
Yeah.
us like that's double the cost for an intervention we could have made if we
Oh,
could
wow.
speak the language.
Hmm.
And now, of course, you've got these tools that's in your pocket going, well, I can speak any language you want me to speak in a heartbeat. You're like,
Right. Right.
that's
Right.
mad,
Well,
right?
listen,
Like
I
that.
I just had a virtual session, and like typically, I'm in Spain, so I do this Sanitas, and typically the doc on the other side does speak English, but I just had a session where the guy didn't, and my Spanish is not
Yeah.
anywhere near, I wouldn't say great, but
Right.
anywhere near, and like we literally like we both had like the
Yeah.
translating app,
And
and
it's
it
good.
worked,
How good
right?
was it?
And it worked,
Was it good?
right?
Was it good?
Yeah,
Did
like
it
I
work?
got everything I needed. Well, he got everything that he needed from me, and I got everything I needed from
That's,
him, right? So
that's
it
wild.
took a
That's
little extra time, but anyway.
yeah.
Um,
Yeah.
so going to now, Chief Clinical Information Officer. What does your day look like? Like, what does that
Is that
mean?
global? Is that global?
Yeah, it's part of a global team. I cover EMEA more than globally. I should fess up. It's a really fancy title. When I like the reality of it is it's a translator. So to answer that, it's that when I arrived at Microsoft, I went around to everybody and I said, "Oh, hey, who is it you talk to?" And they were like, "Oh, we talk to the CIO, the Chief Information Officer, or the IT director, or the whoever." I was like, okay, but what about when you're talking about healthcare? And they're like, I talked to the CIO and the IT director, and I was like, but
Yeah.
like, oh, like I don't even know who that is in my hospital. Like, like that's so disconnected from like what we're
Right.
then trying to talk about or deliver. I had then two reflections on that. One was like we need to make sure we help broker that conversation. So how can I help my teams or the teams I interact with at Microsoft speak the same language, give them the so then we're not like we might have great ideas, but they're not getting out because they're being stuck in the IT department, being filed in the wrong sort of bucket, as it were. So part one, and then part two was going, how do we help go and talk to those guys who probably equally the IT teams aren't out talking to their chief execs or their chief medical officers because they're like, we're IT and we're from different camps. And we say, my day to day, I spend quite a lot of time with IT teams in hospitals, being the clinical voice in the room, and then trying to bring other clinical voices in from the organization or giving them the power to go off and say, right, okay, look, we've heard the voice of a doctor on this. We think this might really help you. Can we qualify it, check it,
Okay.
and do it? Because I think, as we all know, I know we've all had the same experience of great ideas that just haven't got off the ground because we haven't lined up the right stakeholders or the right players to get the game.
But it's interesting. While you kind of prefaced it, and it's a fancy title, but what I really do, and I would actually argue that the work you do is super freaking important for the patients, right? Because there is typically, and it doesn't matter whether it's clinical or not, they're from quote unquote the business and the technical teams. Sometimes you always need some kind of a translator, and great technical leaders actually do deeply understand the business, right? But you can't expect the technical leader to have the clinical knowledge that you've spent years training for, right? And so I'm gonna boost you back up on the
Yeah.
title because
I also, we are awful. I say we, by we, I'm grouping myself with doctors mostly. Like before doing these types of jobs, like I'm classically that person that is like, but the IT's not working. Like, who do I phone up and shout at about that? Like, how hard can your job possibly be to just make my computer work? And I know, like, really hard, like really, really hard. When I also demand that it has to be super safe, that you can't possibly have downtime. That I'm going to ask it to do a million different things on a relatively limited budget in old estates. Like you say, I've got so much more empathy for the job that they're trying to do. And then I think some of our responsibility at Microsoft is to not line up again and be like, oh, hey, you know what, Dave, the idea that you've got all of this stuff to do just to keep the lights on. And then I'm going to be like, oh, hey, give me 45 minutes to talk about an AI chatbot. Like, we've got to do better than that. We're going to be like, we're here to help you keep those lights on. We've got to understand what order we need to bring these things in for. And then, like, what really helps us, like, the reason you've got to keep semi lights on is because too many people keep coming through A&E. Like, is there a way of us having a good conversation about how we might reduce that? Who in your organization do we need to talk to? Because it's definitely not going to be Dave in IT, but he's going
yeah,
to be an important stakeholder later on. Like, and so it's that sort of like what I hate is this. I hate the idea that we've got all of these people working really hard in functions that we just take for granted, and then companies like Microsoft or big tech or whatever else line up and just show something shiny, right? Like I always used to joke, like you can't just buy stuff because the PowerPoint's pretty. But then I
yeah,
was like, we can't keep on showing up with the same PowerPoints. We've got to be able to get and go, actually, we really understand these problems and we want to work with you to get to the game changing point, which is fewer people in hospital, right? Like
Right.
that's what solves the challenge of the overburdened IT teams. And
But
the people that are phoning up shouting about it is because they're trying to have, they're trying to do 5 different things at once. Like we've got to get to the root of the cause, root cause of the problem.
But you must be so like you just being in Microsoft and with all your experience, there must be sh unbelievable shiny objects everywhere that you want to implement. Like just with AI and with systems and like, what's really shiny that you just want to like just get it into people's hands or what how are you thinking about that? Because the innovation space and you're right at the nexus.
Yeah, like it was super like super excited. Like I didn't anticipate. Actually, Ali phoned me up when I like a little bit into my mic when we'd launched the Paypilot stuff. He was like, "How did you know?" And I was like, "What do you mean? How did you know?" It's like, "How did you know that you should join that company?" Like, and they were going to take off. And I was like, I didn't. But one day I'll claim I did if I need to work as a management consultant somewhere. I'll pretend that I'm a soothsayer. Um, I think that the shiny thing at the minute, the thing that I think we would definitely start to implement, not we just as Microsoft, but generally, is ambient technology. So that basically the big problem today, we've put too many people that should be looking after patients behind computer screens.
Okay.
And the first point of that is we've got to take away typing. And I think now ambient tools can do that. Like I remember so vividly when I graduated from medical school and my first proper doctor job, and I had this, my like uncle bought me this like stethoscope. I was really proud of carrying out, and like the senior clinician came up to me and he said, you know, like that's not the important thing. Have you got a pen? I was like, what do you mean? It's like, just never be short of a pen, like, because your job is writing stuff down, filling in forms,
Right.
you know, like that. The thing that you think you would, the pen is most important. And we've replaced the use of the pen now, of course, with computerized systems. And that I think is causing a huge burden on people being like, but, you know, that's why the IT doesn't work. I'm stuck there trying to do this, that, or the other. We've got something called Microsoft acquired a company called Nuance. A big part of why I thought, actually, no, Microsoft are serious about doing healthcare. They bought this company that will, you know, you can dictate into it. It was their first product. The big product, of course, is an ambient technology. So it sits there like we've got a note, you know, like a note keeper in any virtual meeting, captures what was said and then turns it into that note and then saves that time. Like, I think why I'm excited about that is that it's real. Like my prediction
Right.
is every hospital will have it. Everyone will be using one of these in the next 2 years. So it's tangible. And then the reason I think it's really shiny, going back to that original point, like it means that like people get to go home quicker. Like
Right.
it delights people. It gives them value back.
Right.
It's really exciting. If I think about really cool shiny stuff like the robot surgery, like if I could go back in time, I'd be like, I should definitely train as a surgeon because robot surgeons are cool.
Yeah. Yeah. Awesome.
And
Awesome. Yeah.
and the same ambient technology is making those accountants happy as well, right? Because in theory, you're improving those unit economics because a doc can, well, there's two levers there, right? You can either spend more quality time instead of taking notes with the individual. Unfortunately, I think the system is expecting just more caseload. So a lot of these
Mm.
technology and ROI calculations is I'll go from X number of patients to Y versus spending a bit more and maybe a bit more in the preventative care and maybe a bit more on the education side, right? So I'm curious, kind of, again, great tech because I win as a patient, you win as a doctor, the system wins, but I'm curious how you look at it. Throughput or
Yeah.
more with people?
Yeah, no, it's really, I think going back to that original, like, what did I want to do? I think we need more clinical leaders to understand that. Like if you're a management consultant, like my brother's a management consultant, so it's fun to pick on them. You sit there going, well, okay, great, you've got more time, and the sausage factory makes more sausages now. Like, make more sausages, go do that. And then, of course, if you've been in the system, I think we're very lucky in healthcare with empathetic leaders. You go, no, that is not the way to, like, we then have to use some of that time, firstly, to get back the debt that we've caused of everybody being overstretched and no one leaving on time, as a quick example. Secondarily, I think we need to translate that time, and going back to what we were just talking about, maybe even more time with the same patients that stops them coming in 3 times, right? Like, oh, great. Now I'm not so worried about, I've got in my clinic, I get 8 minutes per patient, right? Like, if you do it on the charts that we've got, like,
Yep.
if I'm worried that I've got to spend 3 of those minutes typing or doing something, actually 3 minutes, it's a really, I can convince somebody that they should definitely take their medicine for the winter, take their inhaler for the
Right.
winter in like 3 minutes of having, that's a long time to have that conversation. Now, if I'm
Yeah.
so worried, actually, if I can't really be bothered that I'm just going to chuck a leaflet at them and then get on with doing it, I can't have that. So I think I don't think we necessarily need to push more people through, even though that would feel like it would make the Excel spreadsheets better. But I think in the fullness of time, we'll see that people have adapted. And I think what we then need is also better and strong, continually strong clinical leadership that stands up to that urge of going, okay, well, rather than 8 minutes now, I'm only going to give you 6 minutes per appointment. Actually, if you think about it, that's giving you 1 minute extra back, so you're winning. Like, you have to be like, no, like, I know what's right for my patients. I know what's right for the way that I operate, and like, our job is to serve this population for as long as we can, right? Not just convince them to do the thing there and then. Which is sort of the fee for service model that we have at the moment. Like none of that, the incentives aren't aligned to do that well. Hopefully we'll get there eventually.
Awesome.
You mentioned fee for service, and I also saw that you were doing some value-based care back in NHS. Where do you see, I don't know how much you compare kind of value-based care in NHS and or US, but in general, where do you see that going? Because there's been a lot of talk, and there's certainly more and more contracts, but it just feels that it's so far away. And I think part of that is patients spend the 6 to 8 minutes with a doc, and the doc is now responsible, but the patients are out of the office most of the time, right? So, how do you see the future of value-based care, and where does the AI come in to potentially help or not?
Yeah, probably my favorite topic is, like, I'm convinced that VBC is the way to go. Like, to sort of give it a tagline, like, my favorite way of reimbursement for healthcare is traditional Chinese medicine. You pay your doctor when you're well, and you stop paying when you're unwell. Like, that's a much better way around, right? Like, that sort of
Hmm.
aligns incentives better.
Is
Um,
that how it is?
Somebody told me that, but I don't know if that's still true. But yeah, but
We'll
I love
we'll
the
we'll,
idea
we'll
of,
ask ChatGPT later.
yeah, like,
It's
I have to
great.
go.
Yeah,
I'll
yeah.
have to learn,
But
go to China and find out. But I love the idea that, well, like, now teaching, like, we've got more data than we've ever had. So, the thing that
Right.
stopped the sort of flywheel of, here's Porter's view of value-based care, and you get so far through it, and you're like, oh no, but I don't have the data or the tech to do, like, the block 4 or 5 to then complete the circle. I think we can do that. I think we can do that now, like I say, because we've got the tech. And then the second part is, I think we have learned, because of the pandemic, like a small silver lining, is that people will engage with different ways of care being delivered to them, and engaging with different tools. Like, now everybody can use a phone. We were
Right.
still probably thinking people wouldn't, but we've stress tested it enough to know that enough of the populations that we serve will be able to use tech in some way. So I'm a big fan. I think the UK and the NHS is specifically ready for VBC. I think it's always going to be hard in America because of the way the American system was. I think huge need to do it in America, but less foundational capability. If you think about the NHS, it's a large insurance mechanic already, so we're
Sure.
already up there. We don't compete with each other, like, so we're already quite a lot of the way there. So, like, watch this space. At the moment, that's my big sort of, like, hope for the new technology. Of course, also the problem is, you go, well, I've never had enough data. Okay, great. Now I've got
yeah,
so much data, you don't have enough brain power to sift through it. And then you're like, well, actually, we've solved that with some of the new AI models. So I
Right.
think as long as we can sort of keep on ideating about what that looks like, if we can get the politicians and the politics right as well to get the contracting in place, I think there's quite exciting times ahead.
Yeah, easy.
Jim, before we go to your question, because I can go on this one, I can definitely go for hours, but obviously we don't have that. Maybe just kind of one more, and maybe this is a bit of a, kind of your thoughts and advice to startups. I think obviously there's been a lot of money raised in this hype cycle already, in healthcare specifically, and it's always a discussion on foundational models, the data that's unique to that startup, and your own models and training. There's different ways to slice it, where the companies invest and how do they think about it. So I'd love your thoughts on it since you're close to it, and maybe this is the discussion we were going to have with Ed also, but just kind of maybe kind of compartmentalize the thinking process, right, around it.
Yeah, of course. I mean, and take all of this with a big pinch of salt, of course, anybody that's listening with their own startup and others, because, like, 50% is dumb luck and the other bit is just timing.
Yeah.
Um, I think what my reflections on it. So with Babylon as an example, right? Like we got a huge amount of momentum. We raised a lot of money. We started trying to build a platform. Um, I, on reflection, and of course, easier of hindsight, we should have just kept on solving the thing we were really good at solving for, and not tried to broker it. We shouldn't have tried to get into platform building and all the Asian. One of the reasons I wanted to join Microsoft, I was like, amazing. Like, we raised all that money and we moved the dial a little bit. Imagine if someone like one of the world's biggest companies that can put a Copilot button on every keyboard and change everything. What does it look like there? And my reflection on that is like, we do huge contracts now with countries, it's like in their healthcare. And there are just as many cons to that side. Like, when you're a startup, you're like, I wish I was so big. And of course, financially, that would make a load of sense. But there are a huge number of cons. As an example, with us, right, we've got national tenants that work really well for contracting, but really poorly for innovation at times. So like there are pros and cons to both sides. And when I was one side, I was like, oh, I'd never have seen that until I've got there and felt it. Like intellectually, I might have understood it, but now that I've felt it, I was like, oh, actually, there's a chance there. So my advice would be like, rather than thinking so much I've got to get from A to B to C in order to get from small startup to scale up into massive company that does everything, going much deeper in the problem you're solving is what my advice would be. And by that, I mean, you guys are in it already, but like, hey, I'm really going to help you with your COPD, right? Like, that's my bag. Like, there's so much we can do in individual domains, a bit like pharma, right? Like, we were never going to make a drug that solved everything. I mean, GLP-1s aside, but that's a whole nother podcast.
Yeah, that seems to
But
be
yeah,
solving all kinds of problems. Yep.
yeah, like that. And I'll eat my words, or I won't, but but it may happen if we do that. But like the idea that we were going to find something that was going to be like the take it and everything's done. We have to think. I'd love to see the same with us in digital health and tech. Is going, okay, actually, I'm going to keep on building on the thing that I did. Like the second generation of that is going to have fewer side effects than the first one, and
Right.
we've then as the system will work out how we monetize that or commercialize that in a way that makes the R&D attractive and the others. And then like, rightly or wrongly, it'll be the big guys that provide the platforms, like it's a bit, like no one's going to create a whole new marketplace. And like, so I think
Yeah.
we'll have to lean into that, but we'll have to share the value that's created from it. And that shift from, well, I can only survive if I do everything, to actually there are ways of me surviving by doing the thing that I do really well over the long term with a much longer engagement with patients, will be the sort of the next era.
Awesome.
I have like 12 more in my head, but we'll pause it for over a pint in London, Umang. So with this,
Yeah.
Jim, I'm gonna pass it to you for your final infamous question.
Okay, so go with me into the future here, Umang. You get an invitation from the University of Southampton's medical school to kind of keynote the opening of a new robotics surgical department, and they're asking you to get up and talk about it. And the reason they want you to talk is because of all of you, because you now have implemented, quality AI systems across all of the NHS that's propagated it across the world, and they want to hear how you did this. And you give this great speech and you talk about the importance of focus, with digital healthcare companies and all these young medical students that are thinking about digital healthcare as a field are in the audience. But one in particular, as you're coming off the stage, comes running up to you and just says, I have to talk to you, Dr. Patel, I have to talk to you, Umang. You don't understand. I'm just about to start my own company right now in the digital health space, and I've actually studied in pediatrics, and I grew up, a child of immigrants that opened a community. They had a community shop, and I actually knew Dr. Sang. I was in the same community, or Dr. Sang. I was in the same community, and we have so much in common. And I'm about to launch an ambient healthcare company that's going to solve all kinds of problems across the world. And you looked at them, he says, but beyond what you told us on the stage here, what's the one piece of advice you'd give me?
Great question. I make sure every bit you do offers some delight to everybody that is part of it or using it. I think healthcare is a fascinatingly wonderful place, but mostly it's quite dark, right? Like it's not like you don't come at it for fun. I mean, should I having a baby or other like most of it is fear, has fear involved in it or can take down that. So I think whenever we're doing something new, we have to make sure we bake in the delight. So I would say let to your teams make sure they have a lot of fun whilst they're trying to do it. Understand the prize that they're trying to go for and are delighted to be there. Every user of whatever you have, even if it is a scary thing, what can be delightful for them, be that the UI, the UX, the process, the message, the whatever, but like try and offer a little bit of light into what can otherwise be quite a gloomy place at times.
Delightful.
I was just going to
Delightful.
say it's been delightful to have you with us, Umang. So thank you very much for joining, and for our listeners and viewers, hit subscribe, pass it on, and see you next week.
Amazing.